الرحيم. نبدأ جلسة الومن ايميجينج سيشن. أنا أولا أحب يعني أقول لكم كل سنة وانتم طيبين. أنا طبعا بعتبر نفسي فرد من أفراد التيم الجميل جدا 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 بتاع جامعة عين شمس، وبتشرف إن أنا دايما ببقى موجود معاكم في هذه السيشن اللي أنا فعلا بستفيد منها، وبشوف زملائي كلهم والأطباء وأتعرف على اليونجر جينيريشنز. وعين شمس دايما ما شاء الله فياضة في تخريج جينيريشنز كلهم ما شاء الله، حاجة جميلة جدا بنفتخر بيهم جميعا. أحب أشكر أخويا وأستاذي الدكتور محمد أبو الهدى والدكتورة سحر الفقي لدعوتهم الكريمة ليا أن أنا أشارك في هذه الجلسة، وإن شاء الله تبقى up to the level of expectations إن شاء الله. أنا عارف إن إحنا طبعا برضو يهمني أشكر organizing committee كل من ساهم في هذا، والساينتفك كوميتي اللي ساهم في هذه المؤتمر وهذه الجلسة بالذات. النهارده عندنا مواضيع بصراحة أنا بصيت عليها لقيت كلها مواضيع مشوقة وجميلة وكلها حاجات احنا كلنا بنحب ان احنا نستمع ليها. وهنبتدي ب role of tomosynthesis versus ultrasound in the evaluation of asymmetric breast densities. دكتورة سلمى tantawy هي مدرس في جامعة عين شمس، ان شاء الله هتبقى حاجة جميلة. وعقبال ما الدكتورة سلمى تبتدي توضب نفسها، أنا أحب برضو أتشرف بوجودي في وسط الكوكبة من هؤلاء الأخوة الأفاضل الزملاء الأساتذة اللي معايا في البانل هنا. بشكركم جدا وأتشرف إن أنا أبقى معاكم في وسطكم. دكتورة سلمى عندنا 15 دقيقة، وأرجو بس من الحضور يعني بعد إذنكم يعني نحط الموبايل بتاعنا على السايلنت مود، وإن شاء الله الأسئلة هتبقى at the end of the session. دكتورة سلمى اتفضلي يا فندم.
Good afternoon, everyone. My topic today is breast asymmetries. We're going to discuss this as a diagnostic dilemma, and we will discuss the added role of tomosynthesis and ultrasound in its assessment. Our objectives today are to define breast asymmetries, differentiate these asymmetries from other breast entities, the types of asymmetries, roles and limitations of mammography, ultrasound, and tomosynthesis, and some histopathological considerations. First, we're going to start with the definition of breast asymmetry. It's defined as a localized asymmetric aspect of the mammary gland without a defined contour resembling normal fibroglandular tissue, having or not having interspersed fat, and lacking outward convex margins. We're going to start with the differentiation between it and other breast entities. First, the mass. The mass is a space-occupying lesion in the breast visible in two different projections characterized by its shape and contour. It usually has a convex outer border and dense center. Another entity is the architectural distortion. It's always in the form of thin straight lines or speculations radiating from a single point, and it's also associated with focal retraction, distortion or straightening of the anterior and posterior parenchyma. Here we can see two images, the one on the right in the lower inner quadrant, the upper outer quadrant. These are post-biopsy architectural distortion. You can see the focal skin dimpling and the architectural abnormal architecture. The types of breast asymmetries, they are divided into several types according to some considerations. The number of projections in which they are visualized, the number of quadrants of the breast involved, and the presence of interval changes, whether it's a new lesion, a change in its size, or conspicuity. The first type is the simple asymmetry. It's only seen in one breast view, or one mammographic view, whether the CC or MLO. It has concave outer borders, occupies less than one quadrant, and may or may have interspersed fat. This type of asymmetry is almost always benign. It's usually due to some Mission artifacts. It is classified as a BI-RADS 1 lesion, and some authors recommend 1-year follow-up mammography. The second type is the focal asymmetry. It has the same appearance as the other simple asymmetry, but it is seen in two different projections, the CC and MLO mammographic views. The focal asymmetry, if not palpable by the patient, if it doesn't have any associating symptoms or imaging features like architectural distortions, microcalcifications, it's assigned a BI-RADS 3 classification, And this requires a 6-month interval follow-ups via mammography over 1 to 2 years. However, if it has positive symptoms or if palpable, it will be categorized as, we will move to further diagnostic workup. The third type is the global asymmetry. It's the same as the focal asymmetry, however, it's seen in more than one quadrant. Like we can see here in the two images, it's seen in the CC and MLO views, and it occupies more than one quadrant. This lesion, also if not palpable or not associated with other symptoms, it's classified as a BI-RADS 2 lesion, a benign lesion, a mostly benign lesion, and it we undergo routine follow-up for this lesion. The third type, which is the most worrisome type, is called the developing asymmetry. It's the same as the focal asymmetry usually, however, it has positive interval changes. The other three types didn't have any interval changes and they remained constant along the subsequent mammographic imaging. However, this one shows change over time. We can see here that the images from the right to left are 1-year interval mammographic views of the same lesion encircled in the black circle. We can see it changes in density and in shape over time. And it's also seen in 2 views. The other lesion, arrowed in white, it's a post-biopsy architectural distortion for benign lesion. So our main concern is the other lesion. Almost all developing asymmetries have moderate likelihood of malignancy. This can reach up to 12.8% in screening mammograms and 26.7% in diagnostic mammograms. Diagnostic mammograms include the mammograms that are underwent for symptoms and signs of the patient, follow-ups of benign, probably benign lesions, post-biopsy follow-ups, and 5-year surveillance following conservative breast surgery. This lesion, if found, it's assigned a BI-RADS 0 classification as it requires further workup. We then do the other workup, diagnostic workup, and if it's a true lesion, we assign it as a BI-RADS 4 lesion and it requires histopathological assessment. The imaging of breast asymmetries include 3 major imaging modalities. The mammography, the full field diagnostic mammography, followed by the tomosynthesis and ultrasound as a diagnostic workup. First, the mammography in which we see the lesion. It has a sensitivity of 86% and a specificity of 57% according to the study mentioned. It usually includes 2D, the conventional views, CC and MLO views, and they have some limitations in dense breasts due to the superimposed fibroglandular tissues. Sometimes we resort to a few techniques to make it visible, like spot compression, magnification views, and step oblique views, where we take several oblique views at 15-degree intervals. If it is proven or seen, we move further to the diagnostic tools. Our diagnostic tools start with the tomosynthesis. It has a higher sensitivity and specificity for all breast lesions, not only focal asymmetries. Its main method is to create 3D volumetric images of the breast, and from which we can acquire 2D images and properly assess the lesion from all sides. It detects lesions obscured by the dense fibroglandular parenchyma, so thus it has a higher sensitivity and a higher specificity in dense breasts, higher cancer detection rate, and it reduces the false negatives found in mammography. The technique of tomosynthesis is almost the same as the mammography technique. However, the X-ray tube is not stationary like the mammography. Instead, it moves in an arc around the breast, taking pictures from several views, and then combining those images by software program to reconstruct a 3D volumetric image. It involves a lot of advantages. It's very efficient in assessing non-calcified masses, architectural distortion, breast asymmetries like our subject, and subtle small masses, and it detects site and contour and shape, evaluating also contralateral breast, and it's very efficient in cancer staging to detect the multicentricity, the multifocality, and assessing the other breasts. However, like any imaging modality, it has some limitations that we can address. First is the large breast size. If the breast is larger than the compression pads, we usually resort to compressing only the area of concern, the area of abnormality, or the dense fibroglandular tissue in which we want to compress. Another limitation is the potential false negative findings, especially in extremely dense breasts. Here we can see an image of an extremely dense breast that we can't detect any abnormality inside. So in this case, we call it a mammographically occult lesion, and we resort to other modalities such as the MRI. Here we can see MRI findings that showed a worrisome mass within the fibroglandular parenchyma. Another limitation is the microcalcifications. They are usually seen on mammography as a 2D superimposed image. However, in tomosynthesis, sometimes they are missed or their pattern is missed. So we resort to adjusting the slab thickness. We make it thicker to involve the entire microcalcific cluster, and we can detect the suspicious microcalcifications such as the segmental and linear associated with malignancy, high rate of malignancy. Another limitation is the high radiation dose. Some authors postulate that it's not recommended for tomosynthesis to be a screening method, since we perform a screening mammography followed by a tomosynthesis, which will increase the dose of radiation as a twofold increase. Some authors recommend that we perform the digital tomosynthesis and then we reconstruct pseudo full field diagnostic mammography synthesized 2D images. This will reduce the dose by 40 to 50% and will acquire the same data. Also, the limitations include the cost, availability, storage, and image interpretation time, and this varies among different centers. The third modality that we resort to is the diagnostic tool of ultrasound. It's very commonly used. It's a widely available method. It differentiates all types of lesions, including solid from cystic, small lesions. They detect its features and location accurately, and it has a higher sensitivity in dense breasts. It's also recommended, the first recommended modality in pregnancy and lactation, and it's used as a guiding method in ultrasound-guided core biopsy. The advantages of ultrasound in breast asymmetry include the detection of subtle lesions, like I told before, in extremely dense breasts. It's also very important as a first-line method in suspicious lesions, because if we make or create a positive correlate in ultrasound, we perform an ultrasound-guided biopsy. The technique of ultrasound in breast asymmetry is the same as all breast ultrasound. It involves checking all quadrants of the breast retroareolar region on all hidden sides of the breast in a clockwise manner in two different projections, whether it's vertical and horizontal, or better, radial and anti-radial. We detect the lesion and we detect its criteria and try to characterize it. The very important point to consider here is the accurate localization of the asymmetry, because the asymmetry, if seen on mammography or tomosynthesis, sometimes it's missed in ultrasound because of inaccurate localization. So one of the accurate localization techniques is the triangulation method. The triangulation method, we perform it in mammographic images, like this image. We arrange the images from the left to right, the true lateral, mediolateral, oblique, and CC views with the nipples in line, and we draw a line between the lesion appearing between the three images. This helps us to accurately localize the lesion and perform targeted ultrasound assessment. Like all modalities also, it has some limitations. Sometimes we can detect lesions that have a benign appearance, but they at the end turn out to be malignant. This was a benign-looking lesion that was first thought of as something like a fibroadenoma, and it was diagnosed histopathologically as a triple negative in the invasive ductal carcinoma. Another limitation is the multicentricity and multiplicity of the lesions, obscuring the main lesion and concern, and they distract us from the main asymmetry. Other lesions are the mimickers of malignancy. This lesion had a very suspicious appearance on ultrasound. It has an irregular margin, posterior acoustic shadowing, and it looks like a malignant lesion, and it was assigned a high PIRADS class, but on histopathological assessment, it was found to be a focal fibroadenose. There are also some equivocal lesions that we can find, like this lesion, and it can harbor worrisome features, and this lesion had internal foci ductal carcinoma in situ. Now we're going to discuss some considerations in breast biopsy techniques in breast asymmetry. They are very important because missing the correct site of the asymmetry can overlook very serious diagnosis. There are two major types of biopsy: stereotactic biopsy and ultrasound-guided core biopsy. First, we're going to start with the ultrasound. If positive findings were found in the ultrasound, it's easier to perform this, which is an ultrasound-guided core biopsy. We then must be careful to apply a post-biopsy clip, because we have to ensure after the biopsy that we accurately targeted the lesion and we ensure accurate mammographic sonographic correlate. If it turned out to be positive, this means successful sampling, and if it's negative, we will then resort to a stereotactic biopsy. If negative ultrasound or failed biopsy, like we discussed, we will resort to that stereotactic biopsy. The stereotactic biopsy is very important to be accurately localized, to accurately localize the lesion. To ensure proper targeting, especially because sometimes the lesions are subtle and the field of vision is small, field of view is small, and sometimes the lesions are compressible or effaced, like invasive lobular carcinoma, which can totally disappear upon breast compression. Thus, sometimes we use the diagnostic mammography with an alphanumeric grid to accurately localize the lesion and target it with the stereotactic needle. Of course, examples of pathology encountered, it includes all the pathology of the breast, like any other modality. You can encounter focal fibrosis, radial scar in these areas of breast asymmetry, fibrocystic changes, fat necrosis, infection, or fibroadenoma. There's also an entity called BASH, pseudoangiomatous stromal hyperplasia. It can overlap histopathologically with some cancers like angiosarcomas, thus it requires accurate monitoring. Also, we can find more worrisome features such as the atypical hyperplasia, DCIS, or frank malignancy, invasive ductal and lobular carcinoma. Now we're going to discuss some illustrative cases to understand the subject even more. Some of them are done by our group, and others are found in literature, collected from literature. The first lesion shows a focal asymmetry found at two mammographic views, CC and MLO views. On ultrasound assessment, it showed no underlying abnormality, and it was found to be normal fibroglandular tissue. This lesion is a simple asymmetry found at MLO view, and on ultrasound assessment, it was found to be a well-circumscribed, homogeneously hypoechoic mass, and it was proven to be a fibroadenoma. Another case of asymmetry, this is a case of global asymmetry. It included more than one quadrant of the breast, and on ultrasound assessment, it was found that there was diffuse skin thickening and extensive subcutaneous and mammary fat edematous changes, and by biopsy, it was proven to be chronic non-specific mastitis. Another focal asymmetry found at two views. On ultrasound assessment, a focally dilated duct with a non-vascular echogenic content was found, and it was proven to be epithelial hyperplasia with atypia. This is a case of focal asymmetry also seen at mammography in the upper images and tomosynthesis in the middle images, and on ultrasound assessment, it was found to be focal breast adenosis. The other breast had a small mass lesion. It was proven to be a fibroadenoma. This is a case of simple asymmetry seen at only CC view, and on ultrasound assessment, it showed us this small hypoechoic lesion that was proven to be a focal fat necrosis. Another case of focal asymmetry seen at two mammographic images, and on ultrasound assessment, it showed a small linear hypoechoic branching lesion, and it was proven to be a radial scar. Another case that was collected from literature, it's a simple asymmetry seen at it's a type of asymmetry seen at MLO views. However, it had interval changes. We can see here a 1 year interval between the two mammographic images, and it changed in appearance. This lesion also had a suspicious appearance on ultrasound. It resembled a malignant lesion, and upon biopsy, it was proven to be a granulomatous mastitis. This is another lesion done by our group, another case. It showed a retroareolar focal asymmetry and on the right breast, and a small well-defined mass on the left breast. This right breast lesion was found on ultrasound to be an irregular heterogeneously hypoechoic lesion of slight internal vascularity, and it was proven to be a DCIS. The other lesion was proven to be a fibroadenoma. This is another case of subtle focal asymmetry seen at two mammographic images, and on ultrasound it showed an ill-defined, suspicious-looking solid mass lesion, and it was proven to be an invasive ductal carcinoma. So to sum up, breast asymmetries represent a diagnostic challenge in screening mammography. Diagnostic workup via tomosynthesis and breast ultrasound provide means to increase both the sensitivity and specificity in evaluating breast asymmetries, hence reducing recall rates as well as increasing overall cancer detection rate. Correct sampling techniques play a major role in proper histopathological evaluation. Thank you.
Thank you,
If there are any
Dr.
questions?
Salma. Thank you very much for your nice presentation. And I think the question will be at the end of the discussion, okay? Or at the end of the session. Our second speaker is Dr. Nurhan Usama.